We're a community hospital. People come here and they're being taken care of by relatives and friends. Little happens here that affects just one person or one family or one small sector of the community. When something happens to this hospital, it has great implications to a large sector of the community.
No clinician comes to work thinking that they want to harm a patient. Reducing infection is one of the easiest ways to prevent patient harm. Whenever you focus on reducing infections and get it embedded into your culture, it's just a win for everyone.
Typically, you look at your data and you can compare it to some of your peers, but having the HIN and access to the other data has given us the opportunity then to compare how other folks have done things, see what they did, see that it's measurable, and thus be able to access the data and then implement those same practices.
Probably the best way to change culture is to, first of all, everybody become educated on what your goals and your objectives are.
Purple line is our average right now. The red is our baseline. Green is where we want to be.
Make sure that that's well communicated, that particularly the frontline staff and the leadership are well trained in how you go about this process and what the goals are.
Does anybody have any questions? The staff became involved in reducing infections by implementing best practices that were developed by the HIN. Historically, when we saw a spike in infections, we just accepted it, said, well, we got to do better, and we really didn't drill down into the reason. Now when we see a spike in infection, we drill down, find the root cause of that spike, and we address that specific cause. For example, we saw a spike in our CAUTI rates. We drilled down, looked at the specific patients, and identified that the cultures were being drawn from catheters that had been in place for greater than 2 weeks.
You can't initiate change in a setting like ours through anecdotal information. It has to be empirical data. And what we've been able to do with that data is take it to medical section meetings, take it to nursing leadership meetings, take it to the ancillary departments, take it to our patient harm and safety committee, and show a snapshot of where we are.
To get the catheter out.
The HIN really gave us tools. It taught us how to use data.
To assess why, what happened.
Taught us how to tell our stories in a way that it would spark the interest of our staff and get them engaged. Before the HIN network, nurses would not go and question a physician at all. But now they feel empowered to go and question that doctor. Does the patient still need the central line? Does the patient still need the Foley catheter? Most of the surgeons now. And it's made a huge difference.
We saw here at White River Medical Center a 50% reduction in our CAUTI. Those were our initial results. Part of the reason to reduce infections is not just to meet a metric or celebrate a measure, but when the patients in our community come here, we know many of them.
Shouldn't hurt.
So there's a sacred trust that takes place between the hospital, the caregivers, and the patient.
I need to keep this clean and dry.
The key, though, is not to just let it stop when you get those initial favorable results, but continue to emphasize, because what occurs is that if you don't continue to emphasize, people go back into past practices.
That really was an eye-opener to us.
Clearly, we learn what are the best things to do, but importantly is to continue to emphasize those things so that those initial gains are retained and continue to improve over time. And I think the Arkansas Hospital Engagement Network is a vital part of making that happen.
Thanks for tuning in to HNHN Daily's special coverage of the Health Research and Educational Trust's Hospital Engagement Network. This project has been brought to you by the Center for Medicare and Medicaid Innovation, the Partnership for Patients Initiative, the American Hospital Association, and the Health Research and Educational Trust.